Assalamu alaikum. I am Dr. Junaid and I am Senior Registrar in Pediatrics at Rawalpindi Medical University. Today I am going to tell you about the different Viva questions in the field of pediatrics when you are doing CNS examination. When you are dealing with CNS, the examiner may ask you what is hypotonia, what is hypertonia, what is upper motor neuron lesion, what is lower motor neuron lesion, what are the causes of upgoing planters, what are the causes of downgoing planters, what is crossed hemiplegia, what is uncrossed hemiplegia, what are the where is the exact lesion is, like if you have done an examination of a stroke patient, so he can ask you where is the actual site of lesion, which cranial nerve is involved. By picking cranial nerve, how can you pick where is exact the lesion, what are the spinal segments involved, and so on. So now let's discuss them one by one. When he asks about what is uncrossed hemiplegia and what is crossed hemiplegia, then you need to tell that by uncrossed hemiplegia we mean that the cranial nerve involvement is on the same side as that of the hemiplegia. If hemiplegia is on one side but the cranial nerve involvement is on the opposite side, that is crossed hemiplegia. If only one limb is involved, this is monoplegia. If both the lower limbs are involved, this is paraplegia. If the upper limbs are involved more, this is diplegia. And if all the four limbs are involved, this is quadriplegia. Then the examiner may ask you about the root value of certain reflexes. Like he may ask you, what is the root value of ankle jerk? The root value of ankle jerk is S1 and S2. He may ask you, what is the root value of knee jerk? The root value of knee jerk is L3 and L4. He may ask you, what is the root value of plantar reflex, which is S1? What is root value of abdominal reflexes between T8 and T12? Then he may ask you, what are the deep reflexes, what are the superficial reflexes? About deep reflexes, remember the ankle and the knee, and the bicep and the tricep, they are deep reflexes. About superficial reflexes, you must know that the two A's, the two C's and the PP, they are superficial reflexes. The two A's are anal reflex, abdominal reflex. The two C's are conjunctival reflex, in fact the corneal reflex, and the cremasteric reflex. These are in fact three C's. The two A's, the three C's and the PPIP. PPIP means plantar reflex. By PPIP I mean the plantar reflex. They are all superficial reflexes. The examiner may ask you, what are the causes of upgoing plantars? So remember, the child less than 1 year of age, in deep coma, in hypoglycemia, in post-epileptic fit, the plantar will be upgoing. Also, upper motor neuron lesion, the plantar will be upgoing. The examiner may ask you, in which condition the plantar reflex is absent. So when the fields are too cold, when the muscles of the greater toe are paralyzed, plantar reflex will be absent. When there is loss of sensations in the dermatome of S1, plantar reflex will be absent. When the patient is in spinal shock due to transection of the spinal cord, the plantar reflex will be absent. The examiner may ask you, what are the difference between upper motor neuron lesion and the lower motor neuron lesion? Remember then that in upper motor neuron lesion, the tone is increased, the reflexes are increased and the plantars are upgoing. In lower motor neuron lesion, the tone is decreased, the reflexes are diminished and the plantars are downgoing. There is no muscle wasting, no fasciculations in upper motor neuron lesion, but there is muscle wasting and there are fasciculations in lower motor neuron lesion. Then the examiner asks you, if you find a focal neurological deficit in the examination, where is the actual lesion? In the brain, in the cortex, in the brainstem, in the internal capsule, in the pons, in the medulla, or in the spine. Where is the lesion? So with few tips you can learn where is the exact lesion. Like if your patient has monoplegia, then the likely lesion is in the cerebral cortex, because the cortex has a large area. And if there are certain eye signs, that then with the help of certain eye signs you can identify where is the lesion. Like if your patient have inferior quadrinopia, the lesion will be in the parietal lobe. If your patient has homonymous heminopia, the lesion will be in the occipital lobe. If your patient is emotionally labile and he has a grass reflex which is present, then the lesion will be in frontal lobe. If there is uncrossed hemiplegia, the lesion will be in internal capsule. If there is crossed hemiplegia, the lesion will be in brainstem. Now, where in the brainstem? The brainstem includes the midbrain, the pons, the medulla. How will you decide? You will decide according to the cranial nerve involved. If third nerve is involved, the lesion will be in brainstem. If sixth or seventh nerves are involved, the lesion will be in pons. 6th and 7th. And if the 9th and 10th cranial nerves are involved, the lesion will be in medulla oblongata. If both the upper limbs are involved, the lesion will be above C5 spinal segment. If all the abdominal reflexes are absent, the lesion will be above T8 spinal segment. If there is an element of lower motor involvement, like muscle wasting, then the lesion will be in that specific spinal segment. If there is involvement of specific dermatome, then the lesion will be in that concerned spinal segment. If sensory tracts are involved, like you do the sensory examination and you find sensations up till a certain level, but above that sensory level, a certain level, there are no sensations, then the exact lesion will be a few segments above that spinal segment. Thank you so much.